I think the pandemic is here. It's already here.
Today, we're joined by Dr. Chen, a globally respected specialist periodontist based in Melbourne. He's a clinical associate professor at the University of Melbourne, a former president of the International Team for Implantology, and a leading voice in periodontal regeneration and implant dentistry. With decades of clinical, academic, and research experience, Dr. Chen has helped shape modern implant care worldwide.
Peri-Implantitis is a man-made disease. No implants, no peri-implantitis. So who put the implant in? The surgeon.
You can teach a monkey to place an implant, but that's not the point. You're not here to learn like a monkey just to place the implants. You're here to really understand why.
We're not trained to just drill a hole and stick an implant in. Anybody can do that. We're dentists, and therefore we are professionals, and we need to be able to evaluate things.
We still have patients coming back asking, are teeth worth saving? Given that implants have got good long and good reviews and good history and they do much better. Do you think we should or we should not?
So taking a tooth out is an amputation of a body part. You're removing something that you will never get back again.
Which part of the work do you find rewarding and which part of the work do you find challenging?
Well, I think
Welcome back, Professor Stephen Chen. It's such an honor and welcome to Malaysia, Kuala Lumpur again. I've known Professor Stephen Chen for nearly 30 years now. That shows how
my goodness, that's a long time.
I know, it's such a long time. You were the periodontist in the university when I was doing my undergrad in University of Melbourne, and we all thought, oh my God, he is the periodontist and we really have to look up to him. All of us wanted to be you, at that time. So you were such an inspiration to me and to a lot of my colleagues as well, and that made me choose Perio 4 or 5 years after graduation.
And you made the right choice, by the way.
Thank you. And I remember prior to going to Loma Linda, and I came by your clinic and say, Professor Stephen Chen, thank you so much. I'm leaving Melbourne now, going to Loma Linda to California, and it's unbelievable now that I'm talking to you in Malaysia. So for those who do not know Professor Stephen Chen, which I'm quite sure most do, can you give a quick summary that where your background is and what your current focus of dentistry is now?
Sure, of course. I'm Malaysian, of course, originally, having been born and bred in KL and then in Ipoh.
Wow.
And went to dental school, University of Malaya. So I did my entire education
in Malaysia. We're
right
so
through,
proud.
Right through to university. And I graduated, we finished at the end of 1982. And then, of course, graduation was 83. Mm-hmm. And then I took myself off to Melbourne to begin the Perio program in 1985.
Wow.
And back then it was a 2-year program, but completed it. And my wife and I decided we would settle in Melbourne because it had a lot to offer us.
Yes.
So I guess that's how it all began. That was 40 years ago now.
I know, it's so long ago. But your mom is Australian, and
that's correct.
Yeah,
yes.
that's
so
why.
I've always had a connection with Australia. Mm-hmm. And when I looked around for, because I knew I wanted to do Perio, when I looked around, I thought, well, maybe Australia is not a bad place to go. At least I'll see what the other half of the family have been experiencing and living in Australia. So just one thing led to another and opportunities arose, and that's where we settled.
Oh, that's amazing. I mean, I lived in Australia for more than 10 years, so I know how beautiful it is. Yeah, it's amazing. You were saying you knew you wanted to do Perio. How did you know?
Oh, well, when we were... I think we have to go back to my university training, and some of the things we want to discuss, I think, relates to dental education. And I think the problems that we face now are similar problems with different emphasis on different topics. So periodontics wasn't that well taught when I went through the program. And we did a lot of restorative dentistry. We did a lot of oral surgery, exodontia, and denture prosthetics, and so on and so forth. And I felt one thing that was missing in my armamentarium as a young dentist was Perio. So that's why I thought I'm going to educate myself in periodontics so that I can do better crown and bridge dentistry.
You are amazing.
But then of course the light bulb went on when I started Perio, realizing there's this whole world out there where when you treat patients as a periodontist, you have to put on the hat of a physician.
Yes.
Because we're treating chronic diseases and we're dealing with patient compliance and we're dealing with all the psychosocial aspects of dentistry, and not to mention long-term follow-ups and developing long-term relationships with patients,
which is the toughest.
Yes. So I at the end of my program, I felt I had an affinity for this. I really enjoyed this. Implants came along quite a bit later, you see. So it was Periodontics where we started first.
Yes.
Absolutely.
Perio came first. That was also the same. Well, actually, it was a bit of a reverse. I got into implants first before I realized, Perio is the real thing that we need to know.
Yes, and maybe we are biased, but periodontics is the foundation for all good dentistry.
Yes.
And unfortunately, around the world today, it's not really emphasized as well as it should be. And I think in many cases, it's being reduced in its prominence. And many faculties of periodontics have been combined and subsumed into other departments, I beg your pardon, and mostly, for cost-cutting exercises, unfortunately.
Around the world.
That's the trend that we're seeing, yes.
Yeah. That's very sad, actually, because that's also, the implications are far worse down to the public, to the outside, to the younger dentists as well. Yes. And that's what we are missing out, which is why we're doing this podcast now, trying to create a little bit more awareness.
That's great.
Right?
I think you're doing a great thing here.
No, thank you. So as a fellow periodontist in private practice, I am fascinated by how you have developed your career from running a private practice after your graduation to still double and do so much in academic as well as research and continue to lead big organizations, the world's biggest organization, ITI, for implants. And you were a president and you led and did so many projects together. How do you even manage? Because it looks as if you've got 48 hours a day and the rest of us only have 24 and we can't survive.
I could say the same of you, Jeanette.
No way.
Look, it's funny. You don't really think about it at the time, but you do what you need to do. But I think one of the secrets is you try and surround yourself with really competent people. People who know what they're doing, because you can't be good at everything. You can't know everything.
That's true.
And so if you surround yourself with people who are, I dare say, who are better than you are and more competent than you are, then you just need to go along for the ride. And of course, I had excellent mentors, particularly through the ITI community, who basically showed me the way, and I just followed. I'm not a trailblazer by any stretch of the imagination. I just followed on the the coattails of others. And the other thing, of course, is I had very, very good backup at home with my partner and wife, who is, I guess, very tolerant of my passion for adventures for education. I've always had an interest in education and research, and I think becoming involved in the ITI gave me that opportunity that I wouldn't have had otherwise. So, to answer your question, it's just taking one step at a time and dealing with whatever you are provided or the opportunities you are given. And that's one of the things I would say. If opportunities arise, you can either seize the opportunity or you can shy away from it. I think I've always been someone who's enjoyed a challenge, so I seize the opportunity and take advantage of it.
That's amazing. That's really amazing, because most people see the opportunity sometimes and they're afraid of taking it up. And what gave you the courage to do so much? That's something that some of the younger ones ask me as well. And I would love to hear, do you think through it, or you...
look, I have to say, nothing was planned. You know this.
Yeah, I know.
Fate steps in and you take a step one way or the other, and then that leads you down a completely different path.
That's true.
So at some stage in our lives, we do have to take the chance and the risk and put ourselves out there.
Yeah.
And we see where it takes us. And, more often than not, if the opportunities arise like this, you get it back later in bucket loads. In bucket loads, And
That's
if
true.
you give of yourself as much as you can, and you're unselfish in the in information and the time that you give others, then you reap the reward later in so many different ways, in so many intangible ways that you can't put your finger on.
Yeah.
So for me, it was almost intuitive, but I was prepared to take the chance and to get involved. It was research, clinical research that really drove it, because I was trying to answer the problems that I was seeing in practice.
Oh, cool.
That's
true.
And all the research that I've done, to date, right from the beginning until now, has been to try and answer the clinical questions that I have.
You have.
Yes.
Yeah. And it's so amazing that you get to do research at the same time to find the answers of what's happening in the clinic. And that's how we grow the fastest, actually.
Correct.
Yeah. And not sitting in the university and just decide on what is best as well. I think some part of it is depending on what kind of research we do. Yeah. So which part of it was the most memorable moment in your career journey, actually? And how did it influence you?
The most memorable thing for me in this journey of my career actually happened right at the beginning.
Oh.
And this was when I was introduced to the world of the ITI, the International Team for Implantology. So I was interested in implants in around about 1990-91. We came through the era of guided tissue regeneration, guided bone regeneration, soft tissue graftings. The 80s was a very exciting decade to be a dental student and then, a periodontal student, and then later on starting off in practice. Yeah. And suddenly there was an interest in aesthetics with implants. Originally, it was full arch reconstructions.
Yes.
Which I wasn't particularly interested in. But when it came to aesthetics, that really fascinated me.
And also single implants.
Single implants, single tooth implants, and all the ramifications that go with it. So I was not able to get the training I wanted in Australia. And so I looked abroad, and there was this Swiss implant system that was being promoted. And so that's what I did. I went to America, to Rochester in New York, and did a short program for the ITI implant, as it was known then, with Hans-Peter Weber, so H.P. Weber, who everybody knows very well, was my first teacher. And what struck me was the science that underpinned everything. And even back then, it was all evidence-based.
Yes. Even more so than now, actually.
Well,
sometimes.
in many respects, but also the camaraderie and the fellowship that came with being in the ITI community, that really, really struck a chord with me. So if you ask me what was the pivotal moment, well, that was the moment where a light bulb went on in my head. It went ding, and I went, this is where I want to belong. Because people like H.P. Weber, and then later Danny Boozer, and earlier on Klaus Lang, were people who gave everything of themselves very selflessly, unselfishly, and brought you in and involved. If you were interested, they would involve you. If you showed an interest, come on board and we'll take you along the journey. So my professional career was underpinned by my ITI. ITI partnered me in my professional career because it shaped the way I practiced implant dentistry and dentistry more broadly, because of the principles that were being proposed and being described, enunciated, and developed through the ITI. So I lived the ITI, the philosophy of the ITI, together with my growth in my clinical professional practice. So that's what I say to people. You need an educational partner that will partner you through your educational journey. And so I was so fortunate to have stumbled upon the ITI in it was 1991, I think it was.
In those days, it was not really in Australia yet.
No.
Not even in Asia.
We had to import our implants from America.
Yes.
It was FedExed into us.
Yeah, that's right.
Yes.
That's right. No, but I think one of the main message is the fact that you need to find a place that you belong, and you need to surround yourself with better people, good mentors that guide you through your career.
Yes.
And that's one pivotal factor in your career development. I think
absolutely.
So.
I couldn't agree with you more.
Yeah. So as a specialist, coming back to our topic of periodontics and implants, which part of the work do you find rewarding and which part of the work do you find challenging, actually? So I'm going to give the audience two sides of the story.
Yeah, well, I think the most rewarding part for me as a periodontist is in being able to treat people with periodontal problems and establish health.
Yes.
And give them a healthy dentition. I mean, there could be nothing more satisfying
Dentistry.
than to do this. Because many people don't realize they have a problem until it's pointed out to them, or they're at the late stages. And when you can help them restore health, but also provide them with the tools, the understanding, and the methods for maintaining their own health, I mean, what could be more satisfying than that?
Yeah, that's true.
So this is what I mean. We, as periodontists, we have the physician's hat that we put on. Yes, we do surgery. So it's interesting in the sense that we take off the physician's hat
and then we
put
become
on the surgeon's hat.
Yeah.
But then after the surgery, we put the physician's hat back on because we need the maintenance and the care. That's why dental implants fit so beautifully into a periodontal practice.
Thank you.
because there was this understanding right at the beginning, without the evidence to say so, that our periodontal patients and our implant patients, who, by the way, should not be segregated as periodontal or implant, they're all our patients, need to receive ongoing maintenance care, and to be able to provide them and equip them with the knowledge and the understanding of how to look after themselves.
Yeah. I think we're coming to this era now where we should, what you said is absolutely true, where we should not be segregating perio, implants, or endo or pros in that sense. To a certain extent, we are seeing the patient as a whole. And we all need to somehow share our knowledge, go out there and treat the patient as a whole, rather than, okay, I do my part. If I see a hole, I plug and place the implant. Perio problem is not my problem. Go to a periodontist. And I think that's not the way now.
It's not the way, but that's unfortunately the way dentistry is taught. It's compartmentalized. I mean, there are some schools that try and put that all together in a final year program where you do comprehensive care,
treatment planning,
and you try and put it all together. But that doesn't happen that often.
Yes.
And so you leave dental school thinking in a compartmentalized way.
Thank you.
And so you said, well, I didn't like Perio in my undergraduate program, therefore I'm not going to do much Perio when I go out.
That's true.
But of course, that's not the way it is. It's not the real world. And we have to treat the patient, as you say, holistically. I mean, I always take my students in the postgraduate program. I have a little dig at them if they say, "Oh, I'd like to discuss an implant patient with you." I say, "Well, no, you're discussing a patient with me who happens to need an implant, maybe."
Yeah, that's true. And I think that's entirely our philosophy here as well, because we are trying to bring in different specialties on our podcast to show everyone that you need to understand a little bit of everything, and which is why we were hosting this Tree Masters next year, where we try as much as possible to force people to learn about a little bit about everything, because you need to know the patient as a whole. You can't just specialize and look at yourself and just, that's it.
You know, just a quick anecdote. In June, I think this year, I went to the Quintessence meeting in Boston. Was there for another conference, but it happened to be tagged along. I hadn't been to a general practice conference like this for a long time. And I thoroughly enjoyed listening to all the restorative lectures, all the materials lectures.
Yes.
So you're quite right. You know, we can't separate the individual disciplines. We have to try our very best, and this is the challenge in general practice, isn't it? Because in general practice, you're expected to keep abreast of everything. And, you know, I'm in a specialty, so my excuse is, well, I just follow the literature in Perio and I don't worry about what's happening with the rest of dentistry. But that's not the case.
Yeah, that's not the case.
And particularly with implants, because implants brings in an interdisciplinary component to this.
That's right. And also digital technology is changing things so quickly.
Absolutely.
And it's confusing everyone how you should be practicing. And I think we're coming to a very exciting or confusing stage in our industry.
The marketing that goes with this just adds to the confusion. So I think there's probably a need. We need to step back a little bit and just reevaluate where we're heading. There's no doubt digital technology is going to assist us greatly.
Yes.
But it's also confusing a lot of people and making them feel inadequate if they're not going down, buying the latest scanners and the latest facial scanners and CBCT scans and so on.
And I think the other issue is because there's so many kinds and types of one type of equipment or digital equipment. And the market out there is, some of them are advertising in a sense to the public, and the public are identifying things that may not be the best things for them. So the dentists are being pressured to do certain things as well. So we are going through a very difficult time. So hopefully things will clear up a little bit more.
Hopefully.
Yeah. All right. I know you have a wonderful family with your lovely wife, as you have mentioned, with 3 grown-up kids. And I just want to pivot a little bit to your personal life. A lot of dentists says, "Oh my God, you look at your career. You've gone through so much. How do you balance that?" Yeah. And what advice would you give the young ones? Yeah.
The balance is the tricky thing, and I don't profess to have gotten it right at all, because there were moments where it was so busy that I neglected the children and the family because I had deadlines to meet, and other times where we had the time to do things together. But I think what I always did was I always ensured that during school holidays, at any rate, I would take time off, and we would go away or do something together as a family. So every school holidays, without fail, I would take the time off. So this also meant that I took more time off, and maybe didn't work quite as hard as some of my colleagues because I took more time off. Now, I'm sure my children don't appreciate the fact that I did that, because they've probably forgotten or not realized, and they're all grown up, and when they have their own families, they'll probably appreciate what their mother and father did for them. But I tried my best to do that. So at Christmas, we had a long spell, and then school holidays, and we tried to do things together as a family. And I had there was a rule right from the beginning that we would not combine any of these holidays with a dental conference.
Yeah. That's correct.
Yes, because otherwise I'd disappear and the conference, or I'd be speaking, and then my wife was with
the kids
and the young kids at home, and she would say to me, "Oh, I may as well be at home."
That's true, because you're all on.
Why are we here on the Gold Coast? I'm looking after the kids. You're off somewhere else. I may as well be at home. So that struck a chord very early on, and we made a decision that we would not combine family holidays with anything dental. Yeah. So it also gave me a break.
Yeah. Yeah.
In as much as it gave us time to spend with the
I think that's the best advice, because a lot of people tend to combine for tax reasons and all kinds of reasons, but that should not be the way, actually.
Yeah. So look, life is a series of compromises and sacrifices, and it's within your power and ability to make those decisions, but we have to try and consciously have that balance. I think younger people today are probably more inclined to look at this work-life balance.
Yeah,
a bit
they
more.
are. They are. In fact, too much. I'm sorry to
Maybe
say
it's gone the other way, yeah?
It's gone the other way. It's gone completely the other way. Well, okay, coming back to dental implants and periodontics. As we know that it's becoming so common, patients are walking into clinics asking for implants. You were mentioning about education, but a lot of it is not done in undergraduate education. Do you think that at this moment of time, you've been around the world, do you see a difference in different regions in the world in terms of undergrad education on dental implants? Do they need to know more, or do you think that we are in this era where we need to start changing things? Yeah.
I think in undergraduate dentistry, dental implants are not well taught at all. There are some dental schools that are really trying very hard to incorporate this, and the more progressive ones. But we have to understand the pressures on universities and the syllabus. There are only so many hours in the day, or so many days in a semester, and so many semesters in a year. Yeah. So if they incorporate big modules or a lot of time on dental implantology, something else has to come out of the curriculum. Yeah. And so unless you tack on another year in dentistry, which is not really feasible for most dental schools. So they have pressures on them to try and balance their curriculum. So I do understand the pressures they have. But having said that, I think a little bit more could be done with dental implants in the undergraduate program, particularly restoring implants and understanding some of the mechanics and the occlusion that goes with it. So, why can't occlusion as a subject be studied, but then incorporated into it is occlusion with implants? Yeah. And when you're talking about oral surgical procedures, well, maybe we can tack on something to do with implants, the variation that's required with implants. And in restorative dentistry, when they're talking about taking impressions, well, why don't we just include something on, scan bodies and dental implants? So instead of having implantology taught as a separate subject, once again, we talked about this comprehensive, it's being taught as part of the overall teaching within a university.
That's a very good advice.
Problem is, it requires somebody at the top of the someone who has
institution.
Yes, who has the decision making power to be able to incorporate this. And of course, it means a revamp of curriculum or curricula. So it's not so easy. So what happens, of course, Jeanette, as you know, if you're interested in dental implantology and you want to learn more, you go outside of the university. This is after you finish. And what options do you have? There are actually not many. Unless you're prepared to go back
and do
back to university, do a specialty program, or do a 1-year internship somewhere or a fellowship, and do a deep dive into the subject. Most dentists can only gain access to this through continuing education programs that are run either privately or sometimes through the universities. And there is just an overwhelming amount of courses being run out of private organizations.
Yes.
And unfortunately, the vast majority of them are not really teaching to a sound curriculum.
Yeah. Which is very sad. Which is why when you came a few years back, and told us that we should adopt the ITI curriculum, and we were so honored. And I was in awe of what you've done with the curriculum on the ITI, the online curriculum.
It's a hidden treasure, isn't it?
Yes, it is.
Yes.
It is. It's got so much science and the basic, and it's so concise that anybody can just go on it and listen to it, study at your own time, and be able to grasp as much as possible before you even come in for hands-on or for clinical experience.
Absolutely. It's a wonderful resource, but we need more education providers in the private sector like yourself, Jeanette, you see, who understands that we have to cover the basics.
Yes.
Because education is like a bit like building a wall, right? If you don't have the foundation there and you leave gaps in the wall, at some point it collapses.
Yeah.
And more importantly, if you don't have the fundamentals, you are not able to go back to basics.
Yes.
To first principles, and
especially
problems.
Complication.
Correct. So you need to be able to go back to your first principles and go back to the foundations to be able to solve some of those problems. That's the saying: you don't know what you don't know.
Yes, that's true.
And the hope is that more education providers will do this. But there is, I don't know. It's so confusing out there.
Yeah.
Unless there's some sort of accreditation program.
Which is what I think we have to look into, that because it's coming. I mean, it's time now, looking at the complications that we are having now.
Well, either we self-regulate as a profession and try and build this in, or there will come a time where regulatory authorities will impose this upon us because they start to see more and more complications. All it will take is one or two major issues to arise, bad press. And you know what happens? Then the politicians become very interested in something because it's been raised in the press.
Yes.
And it won't take too long before there's pressure on regulatory authorities then to stamp, to put their foot down. And I think the last thing dentistry wants is outside regulation. So as a profession, we need to self-regulate ourselves. But the problem, of course, is how do you get everyone together? How do you get all the education providers together to come to some sort of consensus and agree to some type of self-regulation?
We just had the consensus meeting, and it was quite funny actually to see some of the voting, and you're wondering, why are there people still voting? Like, how come we can't get to 100% consensus?
It was mind-boggling, wasn't it, Jeanette?
It was.
It was so patently clear what the answer should be. But there you are. There you are. That's the way it is. Yeah. So look, my hope is that going forward, that even dentists who are participating, they start to understand or appreciate the fact that they need to do more than a 2-day hotel-based course. Yeah. And go back and expect themselves to be able to do implant surgery. I mean, how long did it take them as an undergraduate to learn how to do a good tooth preparation? Didn't happen in 2 days.
2 days, that's right.
Why do we expect in dentistry when we come out that we can do things in 2 days? I do a 2-day program and do zygomatic implants.
No way.
But that's how it's proposed, and that's how often it is marketed. Not by everyone, but by enough people out there, enough organizations out there to try and sell it as something simple and straightforward, when you and I know it's not. There's no such thing as simple surgery.
There's no instant noodles, when it comes to surgery. And we're putting a foreign body into the patient's mouth that is not easily retrievable, which I tell patients, and you would like to have it done properly once, and
do it once and once only.
Once only. That's true. So with periodontal disease 10 years ago, it happened much way beforehand when we start looking at the literature and publications. But of course, the hype came 10 years ago, where we understand that periodontal disease patients have a higher risk of having implant complication. And how do you see that happening in your practice, and how do we advise patients, and what do you think dentists should be doing? Yeah, because I think the first line is they don't even screen for periodontal disease.
That's right. We have to go back to basics.
Yes.
But our periodontal patients who are losing teeth are one of the most deserving groups of individuals for dental implant therapy.
Yeah.
So what we have to do, though, is we have to understand what is required to mitigate their risk. They have a risk for periodontitis, and they carry that risk through with dental implants. Unless we can genetically change people's risk profiles.
We've tried.
Maybe it will happen one day, but currently we can't do that. And we can't cure periodontitis that way. Just like we can't cure diabetes or
that's true.
rheumatoid arthritis or all the chronic diseases, all the inflammatory-based diseases. And so what we have to do is use the best knowledge we have. So we know that if patients are treated properly, if they're in a good maintenance program, if they demonstrate compliance, and they don't necessarily have to be the best toothbrushes in the world, but they're complying, they come back for their maintenance recalls, they understand the importance of that, then why not consider dental implants for those individuals, provided you can control the disease in their mouths first. They have to be, I wouldn't say completely disease-free, but they have to be relatively healthy periodontally, well controlled. And then you can consider implants for them. So I'll give you an example. If a patient comes into my practice with advanced periodontitis with stage 4, for example, with teeth that are flaring and so on, and they want to have implants. Well, in my practice, in my hands, they do not receive implants for a long time.
Yeah.
So even if they have teeth that are deemed to be really poor, I say you need to, especially if they haven't been treated, you need to go through a course of treatment with me first. And this course of treatment is actually part of the diagnosis.
Yes.
This is a diagnostic phase of treatment to establish two things.
Whether you're suitable.
Are you suitable? Will you come back for your mate? Do you understand this? And whether your tissues respond to, correctly. Are you a responder or a non-responder? And once we can establish that, then we can start to think about rehabilitation and so on. Of course, you deal with teeth that are loose, you splint them together. If a front tooth is missing, you bond something, and you have to address their primary concerns first. But you have to go along with them in a partnership so that they understand why you are delaying moving on to the next step. Because once you make a decision to go with the next step, then they have to be fully, it's not just fully informed, but they need to understand that they play such a pivotal role in looking after their own health. Because they're a periodontal patient. The diabetic patient needs to understand that they are completely responsible for their care. They don't go back to.
They do.
If they don't go back to their physician, the physician will recall them.
Yeah,
we try so hard to recall our patients. Right?
It's so different. It's so different.
So we have to use this model, and they have to understand that they are responsible for their own care.
Yes.
And so practitioners out there who take out teeth and put in implants on periodontally compromised patients without this understanding are actually, this is a disservice to the patient.
Yeah. We just had one. I had one. Then it's amazing as periodontists because we are called the gum specialists. I had one recently, just last week. I was shocked after so many years of practice that we explain gum disease so well that in her mind, she knows I'm a gum doctor. I'm a gum specialist. I will only come back and see you for the gums. And she decided one day when her bridge broke or some chip to see one of her friends' dentist who does implants. And out they go, just because of a chip bridge, extracted the teeth and multiple implants are placed, and now comes back and asks me, can you check my gums again?
I've had this happen to me from time to time. And for long-term maintenance patients who you think are stable.
Yes.
But I think maybe what we don't recognize is the fact that although they might be stable and they're coming back regularly, they're actually not happy with the way their teeth look. Because we forget to ask that question. We don't prompt those questions any longer. And when I reflect back on a couple of my patients, I realize, maybe I wasn't proactive enough to ask them, is everything all right? Are you happy with the way things are?
That's
And
true.
they might say, Ali, I really don't like the gaps and the color of the teeth. And then we can initiate a discussion.
Yeah.
And, you know, we've got a sign outside that says periodontics and dental implants. And it still doesn't register.
Yeah, it doesn't
So the next thing you know,
register.
they've come in, they've had a full mouth of implants.
Yes.
And you go,
yes.
okay, how did that happen?
Yeah, how did that happen?
Where did we miss this?
Yes. Yes.
Of course, we still continue to maintain.
Yeah,
them.
of course. Of
Yeah,
course.
we don't abrogate our responsibility
Yeah.
to our patients, but maybe there's a complacency within us as a profession for our long-term maintenance patients. Because they keep coming back, we assume that they're okay. And they're
I've learned something today. Yeah, it's so true. Because I was just thinking and questioning myself, what have we done wrong in our practice that
We've
you
done,
don't
done nothing wrong. We've done nothing wrong, but
Yeah.
but we haven't asked the question.
Yeah,
we
maybe.
haven't prompted the question.
Yeah, but that case, the teeth were not ready to be extracted. It's,
Do
it's
you
still-
think there's a role that every 5 years or so for your long-term maintenance patients, you shut your eyes, you close the records, and you bring them in, you treat them as a brand new patient.
I think so.
Take a history once again. Are you
And-
happy with things?
Yeah.
Where are we going?
And do another presenting compliant again.
Do the whole thing all
Yeah.
over again. We don't do this, you see.
Yes, that's true. Because once they go on, they just go on and on and on.
And of course, it doesn't have to be quite as formal as that, but
Yes,
maybe
yes, yes.
you know you trigger in the appointment book. Well,
Yeah.
we're going to allocate another 20 minutes, and we're going to
That's
do
a very good advice.
patient interview.
Yeah. Yeah. I think we need to do that because patients are beginning to be more aesthetically conscious. And of course, the social media is showing all this stuff and they think that dental implants are the ones that are going to do it. But actually, in that case, it could have been done without extracting those teeth.
Yes.
Yeah.
Yes.
And it's very sad
Yes.
to see that people are extracting teeth that
Yeah.
are not even mobile. You know?
I know. So this haste that we have to replace tooth structure with titanium is
Yes.
really quite unsettling, and for me,
Yeah.
because we should be looking at dental implants in most situations as the treatment of last resort,
Yes. Yes.
right? So
Yeah.
you replace your hip because you really can't do anything about it anymore. You don't do a hip replacement because
no good
as a
reason.
first line treatment,
Yes.
you know. So taking a tooth out is an amputation of a body part. You
Yeah.
know? So I think we have to
I
think
like
about
that. Amputation of a body part.
where it is.
We
You-
do have to tell patients that.
Yeah, you're removing something
Yeah.
that you will never get back again.
Yes.
Never
yes.
get back again. And,
Yes.
and the dental and the problems you have on your teeth,
Mm.
you're just going to translate it onto
The implants.
And guess what? Your teeth came for free.
Yeah.
But now you're paying money for the implant, so you're going to feel it a lot more when the implant restorations and the implant prosthesis doesn't work because you're parted with money
That's right.
for it. Yeah.
That's right. And then I think there's one thing that patients don't really understand, or even dentists sometimes. Implants are not the same as teeth.
They are not.
They're not. Yeah,
They're
we
not.
will never be able to replace.
Implants are a man-made device. They're man-made,
And it's still a foreign body.
and all the problems that come with them are man-made.
Thank you. All right. Do you think now, because of all the problems that are coming with it, that implant companies, dental councils around the world should play a role in regulating this? You know, what we have seen.
In a utopian world, yes. But I don't know whether you will ever get that to happen.
What would you like to see?
You know,
in the next-
change only takes place. Everyone's in a situation where most of us are in inertia. We're going in one direction,
Yeah.
and we won't change unless we are, Newton's first law, unless we're
Yeah.
compelled to move in a different direction. So often it's regulation or external factors that force the changes to take place.
Mhm.
So I don't know
You
how.
are one of them. We're
Yeah, but we are opinion leaders, but we are always preaching to the converted.
Mm.
You go along to a conference and the people in the conference
true.
are like-minded individuals. So we don't reach the ones out there who are not availing themselves to this.
Yeah, that's a very
We're
good
not
point.
seeing the Instagram, TikTok people who are doing, they're learning on social
YouTube.
media and are going to courses that are, promise a quick,
Yep.
quick training course, and then you can go back and do, ear-to-ear veneers, for example. I mean, these things happen all the time, and they get into all sorts of difficulty.
Yeah.
So how do we reach those individuals? Maybe the professional groups need to be much more active on social media. We need to play the game. Now, I'm too old to do this. You know,
No,
last
no,
time
you
I
are.
was
Thank you
probably
for
on
doing this.
Facebook.
We are doing this.
There is, of course, there's a role, but I'm not on social media all the time. I just can't come to grips with it in the time
It
spent
takes
on
up
it.
too much time.
Takes up too
Even
much time.
I can't do it as well.
But we, if you're going to have an influence, and maybe we need to be doing a
Yes.
lot more.
Probably a cohesive effort as well. I think that's absolutely important.
Yes.
Yeah. And that's hope. That's what we're hoping to do, and we will discuss this as well.
Yeah, and I think that's the right way to go about it. Too many groups and individuals like us sit back and say, "Oh, I wish things were better."
Yeah.
Oh dear, you know, things can't get any worse, can they? But you know, that's the way it is. C'est la vie.
Yeah.
But not so many people like yourself actually sit down and say, "Well, what can I do about this? Can I actually make a difference?"
That's right.
So this is where I have to give you a lot of credit, Jeanette, because this is, you know, you are on a kind of a mission as well to try and do something. And I wish you all the best. And, you know, from my side and from the ITR, of course, we give you every support possible to do this. And maybe we need more like-minded individuals to come together comprehensively and make a stand and try and shift the dynamic within the educational world.
That's true. That's true. If
we don't want to wait until we are forced to do it by external groups.
And if we were forced to do it at that time, it's going to be even tougher. And people who set the rules may not understand dentistry at that point.
Absolutely. That's the risk.
Yeah, that's the risk. Okay. Just one more thing on the big elephant in the room, peri-implantitis, which is the complication that is talk of the town, social media, internet, everybody talks about it, and patients are beginning to understand that there are risks involved. So we know that the research and publication shows that at the beginning it was 10% all the way to 50% on bone loss around implants with the infection. Then with perimucositis was almost up to 80%. So where do you think now, after a decade, we sit now, and do you think there is hope, or is there a pandemic coming?
I think the pandemic is here.
Okay,
I think it's here. It's already here. And I've been speaking about this in recent lectures on peri-implantitis as a topic. I think we need to change the way in which we look at this. You see, we've regarded peri-implantitis as a disease.
Yes.
Now, if you go back in time, in the 1990s, the surgeons and the clinicians placing implants would say, implants are for life. They will not go wrong. Why should they possibly go wrong?
That's true.
Then we started to see some infective issues.
Yes.
Then the periodontist got involved.
Yeah.
Right. And we applied all the periodontal parameters to implants. So we treated it as a disease. The pocket depths, radiographic bone levels, and so on. So my contention is that peri-implantitis is a man-made disease. No implants, no peri-implantitis. As soon as you put a implant in, then there's a potential for disease. So who put the implant in?
The surgeon.
The surgeon. So it's a clinician. So it's all clinician based. So, and the thing is, we see peri-implantitis as a disease, but in fact, if it's regarded as a complication, if you have a complication with, you know, you've had a knee replacement, heaven forbid, right? You have a knee replacement, and 3 years later, you get a complication, aseptic loosening, infection, fracture, something. So what you do, you go back and you try and track back what the reasons were for it. Yeah, it's not necessarily your fault. Peri-implantitis, we assign all the risk to the patient. Oh, they're a smoker, they're diabetic, they didn't brush their teeth. But if we track it back, was there something that happened at the time the implant was placed that predisposed that implant to an infection 5 years later? Yes. Was the implant completely in bone to begin with? Did we provide good keratinized tissue around the implant to start with? Did we put an implant into an extraction socket where the socket never healed?
Yes.
Right?
Yes.
Right. And I suspect, and I'm doing this in my practice because many of the cases I'm seeing are my own patients, of course.
Yes.
I can go back through the records and I go, I put an implant into a narrow ridge to try and save the patient a bone graft.
Yes.
7 years later, they've got recession exposure because of avascular necrosis.
Yeah.
And in a susceptible individual, that turns into peri-implantitis. You get the circumferential bone loss.
Yeah.
And you open a flap, what do you see? No buccal bone, no lingual bone. The ridge was thin to begin with.
Yeah.
So the problem is, for me, primarily clinician related. And if we start to treat peri-implantitis as a complication as opposed to a disease, then that will force us to think more broadly about the risks. not just focus on patient risk factors.
Yeah. Which is so important, because that message is going to be sent through as actually you need to pick the right surgeon and you need to do the right diagnosis before you place the implants. And because there's so many clinical factors that can alter what goes on.
That's right.
Yeah.
And the rules for implantology were established many years ago. Implants in heel sites, right? All the resorption had happened already.
Yes.
Implants going to predominantly stable bone. Ridges are level to get a broad ridge.
That's
implants
true.
are in with good bone walls.
Yes.
And whether you place it one stage or two stage, it really
It
didn't
doesn't
matter. Those
matter.
implants lasted.
Yeah.
But now we're cutting all the corners, and we're
Speeding things
driving
up.
things up to immediacy and immediate. So we're just increasing the chances of things going wrong.
That's true.
And then we sit back after patients had treatment 5 years later, and there's Peri-Implantitis, and we say, oh my goodness, why did that happen?
Yeah.
We forget to look back at what we did. Did we contribute to this by actually setting up the conditions for it to happen in the first place? And so then it goes on to, how do you stop this? Well, it means we've got to educate. We don't train our dentists to place implants. We have to educate them.
Yeah.
So training someone is to teach them how to do something.
it. Yeah.
Education is to treat them, yes, how to do it, but
How
also
to
how
think.
not, when not to, when to, and how to analyze the risks that are associated with it.
Yeah. And that's what good education is all about.
It's all about. There's a distinct difference between education and training.
Yeah.
We're dentists.
Yeah.
And therefore we are professionals, and we need to be able to evaluate things. So we're not trained to just drill a hole and stick an implant in. Anybody can do that.
Yeah. I think one of my first teacher told me that, I can teach anyone, including the monkeys, to place implants.
Was that Pat Henry, was it?
Yeah.
I heard Pat Henry say that.
You can teach a monkey to place an implant, but that's not the point. You're not here to learn like a monkey just to place the implants. You're here to really understand why.
Yeah.
Yeah.
Yes,
Yeah.
that's right.
A little bit of public advocacy before we're finished. And why do you think periodontal disease is often misunderstood by patients, and not just by the public, also by dentists?
I think that goes back to what I said earlier about undergraduate training. There's not enough emphasis on it. It's being devalued as a specialty in many areas. And it's not particularly well taught.
Yeah.
It's not exciting.
Yeah, it's not exciting and doesn't make you enough money.
Well, actually,
when you do a clean.
What people don't realize is periodontics and maintenance is almost recession-proof.
Yes, it is.
Low
It
overheads.
is. Yes.
People keep. So you want to
And
look at
no
the marketing.
material costs.
No material costs, low overheads, and repeat sales. If
Yes,
you want to use the
repeat sales.
marketing term.
Yeah.
So periodontists know this. We understand this.
Yeah.
But unfortunately, it's not emphasized and not valued enough by our colleagues out there. Now, that's why today at the conference that I was at today was so nice to hear that people talk about aesthetics, but the first thing they talk about is establish health first before you can even think about aesthetic dentistry.
Yeah.
It's a foundation for everything. So, I point the fingers at our universities. I point the fingers at training courses and providers that don't emphasize enough the importance of getting a good, healthy foundation before we start any advanced dental procedure, be it aesthetic dentistry or dental implants or complex crown and bridge work. We have to start off with soft tissue health first.
It's the foundation of everything.
Yeah. And if you do that, you already establish a compliant patient, which means everything you do then has a good chance of
That's true.
Of success.
That's true. Yeah. So for the public, we still have patients coming back asking, are teeth worth saving, given that implants have got good long and good reviews and good history and they do much better? Do you think we should or we should not? Just a very quick one. I know you've kind of answered
course
this.
we should save teeth, because your permanent teeth erupt when you're 6 years of age. The average lifespan.
What's
of
your longest follow-up?
The long, if someone lives to 80, they've got 94 years of a tooth, right, surviving. That's that's far longer than any long-term study we have on dental implants.
That's true.
Right.
That's
so,
true.
And when you have a problem with the tooth, as long as it's not a root fracture or it's not advanced disease, you can manage it and you can treat it. We are stuck with peri-implantitis treatment. There's no consistent method for managing this, and no predictable method for managing it as well. So we have a complication that arises that is not so easily treated. Why would you rush in to give an implant when you have a tooth that would, even a compromised tooth that might give you another 5 to 10 years?
Even a mobile tooth. Yeah.
So as I said earlier, dental implants need to be considered as the treatment of last resort. We have our primary dentition, we have our secondary dentition, and if necessary, we go into the tertiary dentition, which is a dental implant-supported prosthesis of some kind. It shouldn't be the first option we look at for patients.
Yeah, I think that message is absolutely clear, and we need to put that out.
How we convey that to the public is another thing, and that's, I guess, again, it's they go on Google, they do social media. We need more like-minded dentists advocating this in social media.
Yeah. That's true, because they tend to search online and ask the questions with AI nowadays. So I think it's going to change very, very soon. Hopefully, the right information is coming out, and the AI is studying. And I know ITI is on the AI.
Trying how to influence things. Yes. So we need to, organizations like the ITI, all the academic associations, professional associations, we need to be in the game. Where it is at the moment. So if social media is the way in which information is disseminated, then as a profession, we need to be in it as well to convey the good information.
Yeah, I don't think we have a choice now.
We have no choice. No choice.
Yeah, because we have such we still got the future, and we got to help the people.
And podcasts like this will help, Chen.
Yeah, hopefully we can extract. I mean, we've got so many dental polls now from you. Yeah. So just to wrap up, how do you envision dentistry will be practiced in the future? Do you still see it as compartmentalized, or we're going to be coming together a bit more?
I don't know. Crystal ball gazing is very... When we look back, we can see all the pivotal moments to get us to where we are.
Yeah.
If we could project down the future, well, all of us will be trillionaires, and wouldn't have to work a day in our day. If I'd known how well cryptocurrency was going to go, I would have bought Bitcoin 20 years ago, whatever. But it's all in the past. It's the big fish that got away. I think dentistry is here to stay, though. People still have teeth, and people will still have problems with teeth, and will still need to deal with that. How dentistry is practiced may be quite different.
Because we've got robotic surgeries now, so patients are even asking.
Someone still needs to raise the flap.
That's true.
At the moment, anyway.
Yes.
And so I look at it this way. You have a pilot piloting your aircraft. Everything's on autopilot. But if something goes wrong, you want the pilot to be able to take over. What was that? The Delta pilot, I think Sullivan, who landed it in the Hudson River. So a human being had to take over and make those instantaneous decisions about where to put this aircraft down with 200 souls on board.
Yes.
What was going to be the safest for the people on the ground. Now, I don't think there's a capacity for AI to make those emotive, ethical, moral, dilemma type decisions and make a right decision.
Love that. Ethical.
So when we are doing implants as well, and something doesn't go well, we need to be able to go back and become the pilot again and do things manually. And part of the problem with all the training we're receiving at the moment with the digital workflow and so on and so forth and guides. Firstly, you almost can't recognize when the guide is not working because you can't see this. I see this with my postgrad students. And then can you take the guide off and actually then continue?
Sometimes they locked it down and you can't even see a thing.
Can't see a thing. So again, you don't know what you don't know. So I think we need to be very wary of this and make sure that as practitioners and clinicians, we are still able to do the fundamentals. I heard a speaker today, Dr. Yo Untek, say, was asked the question, how all this digital stuff has influenced him. And he said, if you took it all away, I could still practice prosthodontics, right? It would take me a little bit longer. I may need to do a bit more investigation, but I could still practice prosthodontics because the fundamentals are still the same. The fundamentals are still the same. And so as a clinician starting out with implants, you need to ask yourself the question, if you took all these guides away,
are you able to do this
with your brain?
That's right.
As Professor Danny Boozer said, can you do this brain guided? Do you understand the need where the positioning is? Can you see this in your mind's eye? Can you see the end result before you begin?
Yeah.
So this is something that I think is at risk of being taken away when we turn everything back to digital. On a computer screen, and then we have a guide that's printed, and we have to then translate this digital stuff to the analog world, because believe it or not, treating a patient is still analog.
Yes.
Even though you've got guides,
Yes.
you still pick up the handpiece.
That's right.
It's still analog. And I think robotics is still a long way away anyway.
Yeah.
So yeah, there it is.
Yeah. But we might see some changes soon enough.
We might.
Coming to the end, thank you. This was started because I wanted to make every day a little bit more joyful. Optimist was created in the 1960s, actually, by a Danish guy.
Optimist?
Yeah.
I didn't know this. Oh, this is very cute.
He is the origin of smiley face.
Okay.
And that's why we wanted to do this podcast, because this is not a toy.
Yes.
It's really not a toy, it says here.
It's not a toy.
It's not a toy.
Thank you very much.
We wanted the best out of dentistry, and for everyone to bring some joy. And hopefully this session, you've enjoyed yourself, and thank you for sharing.
Very much, very much. It's always nice to chat.
Yeah, thank you. Thank you. We're going to bring you back, and there's so many more questions that we need to ask.
Thanks, Jeanette.
No, you're welcome. This will bring a bit of joy for you, and hopefully you'll remember us.
Thank you.
Yeah.
Thanks to everyone.